So today I want to talk about two separate but related programs. The first is called Medicare Direct Contracting, but it's also going to be replaced by a similar and even more dangerous program called REACH. Both of these programs pose a major threat to seniors and to the future of traditional Medicare. And in this presentation, I'll explain why direct contracting and REACH are so dangerous, why they must be stopped, and what you and I can do to stop them. How does that sound? Good? Okay. So first, let me explain a little bit more. I know it's confusing to talk about two programs at once. So I'll give you a quick history of direct contracting and REACH and why I'm talking about two programs at the same time. So you'll see in 2019 and 2020, Medicare Direct Contracting was developed in the Trump administration. It was launched in April of 2021, so less than a year ago. Me and folks like us have been campaigning to stop Medicare Direct Contracting for the past few months. And then just recently in February, Medicare announced that it was terminating direct contracting, and it was announcing the development of a new program called REACH. And REACH is supposed to begin January of 2023. So that's why I'm talking about direct contracting. It's happening now. It will be replaced by REACH this coming January, so a little less than a year from now. That's the timeline. So now that you kind of know generally what we're talking about, let me explain how direct contracting works. Because like I said, REACH is basically a carbon copy of direct contracting. And if you hear me use the names interchangeably, that's why. So direct contracting is a pilot program that was launched late in the Trump administration as a way to change the way that Medicare pays for seniors' care. Instead of paying doctors and hospitals directly, Medicare gives third-party middlemen called direct contracting entities, or DCEs, a monthly payment to manage seniors' care, which allows them to keep as overhead and profit what they don't spend on medical services. That's the basic framework. So traditional Medicare, this is the starting point. This is where this program is happening. Traditional Medicare, Medicare pays providers directly for patient care. It's pretty straightforward, pretty transparent. Now in direct contracting and REACH, Medicare is paying a middleman a set amount each month to manage patients' care. And I'll say manage in quotes because we're not exactly sure what that means. So these companies, they're a middleman in two ways. They're both a middleman between Medicare and the provider and a middleman between you and your provider. And before we go on with the details, I just want to see, has anyone here ever heard of direct contracting before? Anyone raise your hand? No. Well, you can't raise your hand, that's cheating. So if you haven't heard of direct contracting, it's not because you're not paying attention, you're in good company. Because until recently, most Medicare beneficiaries and even most members of Congress had never heard of direct contracting. So that begs the question, how could such a radical change to traditional Medicare happen under the radar? Well, the answer is that it was developed by an obscure agency called the Center for Medicare and Medicaid Innovation, which you've probably never heard of either. So let's take a moment just to see what we're talking about. So as I said, direct contracting is born out of CMMI. And this is an obscure agency that has the power to implement pilot programs and scale them up to all of Medicare without congressional approval. Now, where does CMMI fit into our National Healthcare Administration? So this is a chart of Health and Human Services, and that's the agency that's responsible for most of our healthcare system to the extent that we have one. So, the FDA, CDC, all these agencies that you've probably heard of a lot recently. The head of HHS is Xavier Becerra, and he is appointed directly by President Biden. So he reports directly to Biden. The president is his boss. Now, Medicare, which is what we're talking about, is run by another agency within HHS called CMS, the Centers for Medicaid and Medicare and Medicaid Services. They kind of drop the middle M there. That's an agency within HHS. So now we're going to look at CMS. If you put on your reading glasses and look really closely, you can see that CMMI is an agency within CMS, there it is, and it's run by a person called Liz Fowler. She's the director. Now, again, this is a pretty tiny agency, but it has a lot of power. So they're actually very important. It's important to remember that everything this agency does, they can scale it up to all of Medicare without a yes or no from Congress. So now that we know a little bit about this agency called CMMI, let's look at who was in charge of CMMI when direct contracting was first developed, because there's a very interesting backstory here. So this fellow here is named Adam Baylor, and he was a former roommate of President Trump's son-in-law, Jared Kushner, who you've probably heard of, and he ran CMMI when direct contracting was first proposed in 2019. But before he was at CMMI, Baylor ran a startup called Landmark Health. Now, Landmark Health later became one of the first companies to win a contract with Medicare to be a direct contracting entity. Not good. So if you thought that was a fun story, we can do it again. So after Adam Baylor left CMMI, he was replaced by a young man named Brad Smith. And before Brad worked for CMMI, he previously worked for the commercial insurer Anthem. And have any of you heard of Anthem before? Probably, yeah. They're very, they're a big commercial insurer. They're very active in Medicare Advantage. And so then he used to work for Anthem. And then Anthem became a direct contracting entity through its CareMore subsidiary. Now, this fellow, Brad Smith, he's no longer with CMMI. He now runs an investment firm called Russell Street Investors, where his team actually includes a group of other CMMI alums. So there's a lot of revolving doors going on here. So there's two examples of how this revolving door has really been a gift to these industries, to these DCEs. So if this all seems pretty fishy to you, it's because it truly is. And HHS's own watchdog was shocked to see that the draft program proposal actually listed some of these companies by name and said it raised very serious ethical concerns that the program was established specifically to benefit these companies, several of whom won contracts to be DCEs. So the Office of General Counsel warned, but the agency didn't do anything about it. This is the program that we're basically stuck with. So now that we've kind of peeked under the hood at the agency that brought this program, let's look more closely at what the DCEs are. Who are the people running the actual direct contracting entities? So right now, there are 99 DCEs currently running. They're in almost every state in the US. They just released kind of a new batch of DCEs, so we haven't mapped out exactly where they are, but it looks like they're in pretty much every state. And virtually any type of company can apply to be a DCE or reach middleman. It includes commercial investors, as we saw, Anthem, a lot of private equity investors, Wall Street investors. And importantly, applicants are approved without any input from Congress. So it's CMMI that is approving these contracts, investigating the owners. And then if you look at, here's one example of just one DCE that's currently operating. Its name is ILUMED, and they do not capitalize their name for some reason. And as you can see here, this is their management team, their leadership team, and only one member of the team is an actual medical provider, has any kind of medical experience. And this woman circled here is a registered nurse. It doesn't seem like she's practicing now. And if you dig a little deeper, you go on the news page of their website, it gives you a good flavor of what their business is about. So the two main news articles here. So they most recently hired a chief medical officer that they recruited from insurance giant Humana, which you've probably heard that name. They're also very active in Medicare Advantage. So that kind of gives you a sense of where he's at. And then just as important, or maybe more important, is this news that they pulled in $16.5 million from investors. So they're as you can see, Wall Street investors are really interested in putting their money into these companies. So it makes you wonder, why is Wall Street so interested in a company that claims that it's going to be saving money for Medicare and improving quality for patients? Where is the money in that? And if you step back and look at this model, you see, we went from traditional Medicare, where Medicare's paying providers directly, to direct contracting. We're paying the middleman to pay providers. But there's another set of players that we haven't really talked about, which are the Wall Street investors who are backing the DC and REACH middlemen. And they're really just flooding these companies with new money. So again, how do companies who claim they're going to save money, how are they going to keep these investors happy? Obviously the investors are expecting to make a profit. So here's a breakdown of the business model for direct contracting and REACH. It's a three-pronged business strategy, which is similar to most businesses. They need to maximize the revenue from Medicare. They need to minimize the revenue that they're spending. This would be on patient care. And finally, they need to increase their volume through enrollment, because they're not going to make a lot of money with just 10 enrollees. They need thousands and thousands for this business plan to work. And we talk about maximizing revenue. It's a little bit complicated, but I think it's important for you to understand what this means in terms of managed care. So they do this little trick that's been going on in Medicare Advantage for quite some time, where they do this thing called upcoding. They make seniors look sicker than they really are. And the reason is because REACH entities and direct contracting entities are paid a monthly flat fee from Medicare per enrollee. But the sicker the patient looks, the more money they get from Medicare. And this has nothing to do with the amount of care that beneficiaries receive. It's only based on these diagnoses. It's a little confusing. So here's a visual example. So here's a chart of a 76-year-old female patient with some pretty common diagnoses. Now, each condition gets a score, and you add up those scores, and that tells you how much money Medicare will pay the REACH or the direct contracting middleman when you add that up. So in this example, the REACH DC middleman will get $9,000 per year based on this potential health needs, we'll say. Now, here's an example of that same person, 76-year-old female, when there's upcoding involved. So you see here, obesity becomes morbid obesity, and it's got higher points. Diabetes now includes retinopathy, asthma is COPD, and so on and so on. Everything in red is where they've upcoded. Again, same patient, nothing's different, just the way that they track and record these diagnoses. So now if you add all that up, Medicare's paying this particular middleman $32,000, so more than triple what they were paying before. And this again is just not based on healthcare, not based on services provided, just based on record keeping. So it is really, they're really maximizing the revenues in that situation. And we do expect to see that in this program. So their next strategy, now that they've gotten all this money from Medicare, how do they keep more of it for themselves? And it's important to know that within traditional Medicare, there's not really an incentive for anyone to restrict care. But when you introduce these middlemen who are allowed to keep as profit and overhead what they don't spend on medical services, now you've got the incentive to ration and restrict care, because they get a flat fee and they're allowed to keep what they don't spend on care. It's a complete change from traditional Medicare. So again, these incentives do not exist in traditional Medicare. This is probably the biggest single change that we've seen. And then finally, they got money coming in, they're keeping money from going out. How do they amplify it? How do they make it bigger? So if you're on, you look at most healthcare middlemen, commercial insurers like Humana or Aetna, they have to convince patients to enroll. Thus their massive marketing campaigns. And I'm looking at this guy, Joe Namath. If you turn your TV on anytime between September and December, you're going to see this guy 24 hours a day, right? Because they have to convince people to join up. But in direct contracting and in REACH, they don't have to do anything because Medicare, CMS automatically does it for them. And this is how it works. So Medicare will automatically search seniors, 2 years of seniors' claims information, claims history. And if they find a primary care physician that you've been seeing that is linked to a direct contracting or REACH middleman, they will automatically enroll without your consent. They call it aligning. They automatically align. So if a senior's primary care physician, even if they've seen multiple physicians, if their main primary care physician is affiliated with a REACH or direct contracting middleman, Medicare will automatically align them without the senior's consent. And again, this is nothing that we've ever seen in traditional Medicare before. And it's all done under the radar, behind your back. So if you are aligned, you may get a form in the mail, or you may get an email that looks something like this. This is an actual letter that someone sent us. And if you're like me, you're going to see that no action needed, and it's going to go straight into the recycling bin, right? Because most of us, when they see a long letter and it has something to do with insurance or something to do with healthcare and it says no action needed, it goes straight into the trash. So what can a senior do if they're aligned to the DCE without their consent and they don't want to be? Unfortunately, the only way to get out is to change primary care physicians. And CMS told us this themselves. This is the only way to get away from these middlemen. And that's tough for anyone, but if you think about those with complex health needs or those who live in rural or other underserved areas, it's virtually impossible. And we feel that asking seniors to change their primary care physician undermines traditional Medicare's promise of a free choice in provider. So again, a very radical change to traditional Medicare. I know that we've talked about kind of the dangers to individual seniors and adults with disabilities who are enrolled without their consent. I want to take a minute to talk about the future of Medicare itself, which should be a concern for everyone, because eventually we're all going to need it. And when I say that DC and REACH threatens Medicare solvency, it's a fancy way of saying it could bankrupt Medicare, because we're looking at traditional Medicare is very efficient, spends 98% of its budget on care, but DC and REACH, they're allowed to spend as little as 60% of what Medicare pays them on patient care, keeping the other 40% on overhead and profit. A huge change from traditional Medicare. And this is what that looks like. So you see traditional Medicare, 98%, 2%, that's pretty good. Even Medicare Advantage, it's not great, but they are required to spend 85% of their revenues on patient care and keep 15% as overhead and profit, which they usually do. Now, there's no such rule for REACH and direct contracting middlemen. There's a pretty complicated what they call risk corridor, but basically they're allowed to keep 40% of what Medicare pays them as overhead and profit. And it's kind of an eye-popping amount, especially when you compare it to traditional Medicare that works pretty well. Now, again, if you're worried about this expanding to all of Medicare, this is absolutely CMMI's goal. And they've been saying this for the past 6 months or so, that their goal is to move all Medicare fee-for-service, which is what traditional Medicare is, beneficiaries into these accountable care model. So moving them into REACH or something very much like it by 2030. That's 8 years from now. They want all of this to move up to all of traditional Medicare. So this is happening very, very quickly, which is why we need to get busy stopping it. So where do we go from here? I told you a lot of kind of scary information, but the good news is that we're building a grassroots movement to stop direct contracting and to stop REACH. So I want to tell you a little bit about what we've done so far and where we're at in this campaign. So just this past fall, this has all happened pretty quickly, a group of physicians pictured here, they delivered a petition to Secretary Becerra and met with a lot of members of Congress to educate them about what was going on. In January, more than 50 members of Congress sent a letter to Secretary Becerra demanding an end to direct contracting. It got a lot of attention. And then just about a month ago, Senator Elizabeth Warren spoke out about direct contracting in a Senate hearing, which also got a lot of attention. And those are all kind of big, important people. But in the meantime, we've had thousands and thousands and thousands of grassroots activists, like folks like you, who've called HHS, who've called their members of Congress, who've written letters and op-eds, have gotten tons of media attention, made lots of good trouble, and really put the pressure on HHS and CMS to end this terrible program. So there's been a lot of activity. And basically, through all this activity, we've made direct contracting a bad name. It's a toxic name now. CMS knew that it had to respond. So on February 24th, the agency announced that it was, in fact, going to cancel Medicare Direct Contracting. But there's a twist. They wanted to replace it with a virtually identical program called ACO REACH. And I like this headline because it's basically what they did. They gave it a makeover. They put some lipstick on it, but it's basically the same program. And I think this Wall Street investment analyst, his name is Spencer Pearlman, he said it best. This is from a report that came out the day after CMS made their announcement about replacing direct contracting with REACH. He said, the reforms are one part public relations exercise and one part modest revisions that should not tangibly impact the for-profit entities currently participating in the model. So the industry was not worried. They were worried for a little while, but when they saw what the REACH program was, they were not worried at all. So let's talk about what are some of the things that are still in the REACH program. What's basically everything that I've talked to you about today. There's still a middleman between Medicare and providers. They can maximize revenues by upcoding. They still have that profit incentive to restrict care. They can keep 40% into their pockets. They automatically enroll seniors, and anyone can apply, including private equity investors and commercial insurers. So we fully expect everything that we didn't like about direct contracting to be in REACH. So in some ways, it's actually worse. When you read the fine print, we saw that there were some big giveaways to the industry. They lowered, I don't want to go into the details of this, but they basically lowered the penalties for the middlemen failing to control costs. They lowered the penalties for failing to improve quality or maintain quality. And they said that any middleman who's currently in direct contracting can just roll into the REACH program. They don't actually have to reapply. So all of the folks that we've met so far in this presentation, they can all just roll right into it without that much problem. Now, CMS made kind of a big deal about focusing on equity, which is something is probably important to everyone in this room. It's important to me. But when we looked into some of these equity incentives, we realized that they're either meaningless or they're encouraging profiteering in underserved communities. And that's a big red flag for all of us. How are they doing that? So first, Medicare is providing the middlemen with a financial bonus simply for reporting demographic data like race and income. Now they're not using that data to hold them accountable to any type of outcomes. It's just you report the data, we'll give you extra money. Next, they're going to pay the REACH middlemen $360 per year simply for enrolling underserved beneficiaries. And again, this does not matter how much care that they provide, simply for enrolling them. And they're going to do something that's a little complicated. They're going to allow the REACH middlemen to use demographic factors to increase the risk scores. So we talked about using people's, inflating health diagnoses to increase those risk scores to get more money from Medicare, that upcoding. Now they're actually letting the middlemen in REACH not just use health diagnoses, but to use demographic diagnoses like income to say, now I need more money from Medicare because I'm treating someone who's low income. Again, they're not providing additional care, they're just getting more money. And then CMS said, well, we're going to make these middlemen fill out an equity plan. And okay, that sounds pretty good, right? An equity plan. This one was kind of a shock to me when I looked at it. They said, okay, you have to fill out an equity plan, but we're going to give you a template, a worksheet basically that you can fill out. And this is what it looks like. I can actually put a link in the chat of this so you can you can look at it yourself. But this is the so-called, here's the link in the chat. This is the worksheet that they have to fill out. There's a couple more pages to this, but this kind of gives you a sense. And I think, you know, this looks like something my 5th grader would do in social studies homework. It's very simple. It doesn't seem like this is very, if someone's trying to be serious about improving health equity, they would do something a little bit more serious than this. So, all right, so how do we stop REACH? Now we've kind of ended up with this program that's in some ways even worse than Medicare Direct Contracting. How do we solve it? How do we stop it? And we know that Wall Street's not going to give up this cash cow without a fight. So we do need everyone who cares about seniors, who cares about those with disabilities, and cares about the future of Medicare to get involved. We do know that the agencies will respond to pressure because they did, you know, they did something, it just wasn't good enough. So how can people get involved? For individuals, the best thing you can do is sign and share our petition. We've got thousands of people on it, but we need to get a whole lot more. We need to keep that pressure up. And for those in the speakers training, I should say we're working on kind of a rebranding our materials. So this will probably change, and I'll update that. You can write a letter to the editor in your local news outlet, and we've got some great talking points and guidelines. And if you're an organization, you can sign on to our organizational letter against REACH and Medicare privatization. And for organizations, you can share the petition with your own members, because again, we need to get thousands and thousands and thousands of people on this list. And that's it for now. We've got a lot of, you know, we're gonna fight over the next few months. We've got a lot of activities coming up, a lot of activities planned, and we're gonna need everyone to get involved. So if you sign the petition, we'll have your email. You can give me your email, and we'll keep you updated on everything that's going on in our fight to stop direct contracting, REACH, and Medicare privatization.